Okay, so we're going to talk in a little bit more detail about high flow nasal cannulas and then the difference between that and some conserving devices, and just really make sure that they're clearly divided in your mind. These are your references if you need them. So really quick, just looking at our air oxygen blenders. When we go into lab, you guys are going to look at two different kind of blenders that we have. One is a two-source blender. This is what we're using at Gunderson. It has an oxygen and a room air connection, disconnection that plugs into the wall. If you plug it in and you plug in your air first, your oxygen first, and you don't have the second gas source plugged in, you hear a very loud, high-pitched alarm. And the reason it does that is it's set up where if there's any more than a 5 psi difference between the oxygen connection and the room air connection, it wants to alarm. And it's just a way of telling you that it's not properly hooked up and there could be a problem with your ability to deliver a specific FiO2. So you have an air oxygen source. It then gets drawn in, and there's a proportioner that will give you a specific FiO2. It goes from 21% all the way up to 100%. So it's one blender we're going to look at. The other blender that we're going to look at is a single gas source blender. This is the one that they use at Mayo. So it has just an oxygen disconnector. And what happens is the device itself has a Venturi system that will entrain room air into it, and it will proportion the FiO2 that way. I don't want you guys to link it with your large volume jet neb or with your venti mask because it's not limited by those magic box equations, because you have a flow meter that goes to at least 60. So yes, it entrains room air. Yes, it works through the Bernoulli principle, but you guys are not going to have to worry about calculating what its maximum total device flow is, because it still has that separate flow meter that at least goes up to 60. And we know that 60 liters per minute is kind of our magic number for covering all of the inspiratory flow needs. So I don't want you to link it in the sense that you have to do a magic box for that device, because you don't, although it does entrain the room air in. What makes that different from the two gas source is you can't actually get down to 21%. I think the lowest FiO2 on Mayo's blender is like 24% because of that single gas source. So that is the difference of the two blenders that we're going to be looking at in lab. When you're using a blender for high flow oxygen, whether you're using a mask or a nasal cannula or a trach or any of the many interfaces that you can put on them, you must have heated humidity. And the reason why, and I've said it in previous PowerPoints, is when you get to those higher flow rates, you are bypassing the upper airway, because that air is moving past the mouth, the nose, all of your mucous membrane so quickly that it doesn't have enough contact time to pick up the proper humidification before going into the lungs. And that's what this whole unit is about, is understanding why humidity is important, how we can reproduce the body's natural humidity when we're using medical gases and ventilators and tracheostomies and all these other things that we use, so that we can keep lung health optimal, and we can keep people from getting worse due to secretion retention, mucus plugging, cell damage, tissue damage, all kinds of things like that. So if you're using a blender, you must have heat and humidity, always, always, always. So again, looking at the air oxygen blenders, they have adjustable flow rates, some of them up to 100 liters per minute. But at the very least, all of them go up to at least 60, which again, we know is that magic number that's going to cover all the needs. Some examples of the interfaces you guys are going to be looking at are a high concentration aerosol mask, high flow nasal cannula, a trach cradle, a T-piece, a face tent, and we'll see those all in lab this coming week. Just to really kind of separate the low flow nasal cannula versus the high flow nasal cannula. Most of the time with the low flow nasal cannula, the maximum flow you're going to use is 6 liters per minute, which is approximately 44%. When you get to over 4, you're going to add a bubbler, just because at those higher flow rates on nasal cannulas, they start to get pretty uncomfortable. They cause nasal congestion, irritation, nosebleeds, discomfort. So we add the bubbler in to try to assuage that a little bit. There is another kind of cannula that you guys have not seen in lab yet that can deliver a higher FiO2, and it's called a reservoir cannula or an oxidizer. I feel like more often in clinical settings, you'll hear it called an oxidizer. On the boards, they refer to it as a reservoir cannula. That's one where we're going to talk about it a little bit. You don't use humidity with those ever, ever, ever. They're still considered low flow. They're not a high flow nasal cannula, even though they're bigger and they can go up to higher flow rates. They're still low flow. What makes them different, and you'll see in a little bit here, is that they actually have a reservoir similar to like the non-rebreather or the partial rebreather, where they trap 100% FiO2 and sort of limit that patient dilution of room air. Obviously, the other nasal cannula that we're going to talk about that can deliver a higher FiO2 is the high flow nasal cannula, and that's the one on the blender where you would add humidity. So, reservoir devices for the cannula. There's 2 main kinds. This is considered a mustache nasal reservoir, and this is a pendant reservoir nasal cannula. Again, more commonly in clinical, you're going to hear these called oxidizer, so mustache oxidizer or pendant oxidizer. Different patients have different preferences for one versus another. We carry both, and you kind of see what they feel more comfortable with. But what happens is this area here, if you look at all of this extra room, that's designed to hold oxygen, right, to build it up as it comes from the flow meter. This is also designed to hold oxygen as it builds up from the flow meter, so that when a patient is breathing in, they're much less likely to dilute as much of that FiO2 with room air, because they have this reservoir here that's trapping 100% oxygen and limiting some of their room air dilution. Still a low flow nasal cannula, guys. I can't stress that enough. This is low flow. The reason you can't use humidity with these is because there's a tiny little membrane in here and a membrane in here that works so that when you inhale, it opens and it lets that extra oxygen that's been collected flow into your nose. And then when you exhale, that membrane closes back down to trap the 100% oxygen and begin to refill it. That's how it's designed to work. If you add humidity, those little membranes in there get stuck, and then it does not operate effectively, and you can actually see saturations drop. So when you're talking about an oxidizer or a reservoir nasal cannula, you may not use any humidity. It doesn't work, and it is still a low flow device. So on average, this stores about 20 mils of oxygen. You don't really need to know that for anything, but that's about the size of them. It can reduce your oxygen use as much as 50 to 75%. And what that means is, when you get where these come in very, very handy, is when you have COPDers that are getting to the point where they need 4 or 6 liters of oxygen with activity. That gets pretty difficult, not only from a comfort level to wear all the time, because it's a lot of flow going in your nose, but also from a tank conservation standpoint. You guys have done your tank duration math. You know, if you start to get to those higher liter flows, you really cut down the time that your tank will last. So on average with reservoirs or oxidizers, kind of the way that we figure it out is, if somebody's wearing a 4-liter normal nasal cannula, they might just need a 2-liter nasal oxidizer. Or if they're wearing a 6-liter normal nasal cannula, they might only need a 3-liter oxidizer. So you can cut those flow rates way down. And there's 2 reasons that works. One, we talked about, which is the reservoir that traps that 100% oxygen and limits the patient bringing in as much room air. The other reason is the cannula is much larger, which you guys will get a chance to see in person, but you can kind of see it in this image here. And the prongs fill up more of the nair than normal low flow nasal cannula prongs. And so this also is going to limit that room air dilution by the patient and keep that FiO2 much more concentrated. So typical home care use is about 1 to 10 liters for a reservoir cannula. I don't want to say that 10 is like a hard maximum, because I've definitely seen people higher than 10 liters, but this is, I would say, pretty typical. Hospital use, you can go up higher. You generally, if you're going to be on a 12-liter oximizer, are going to have a patient on a high-flow nasal cannula blender. Where we use these instead is some hospice patients or palliative patients. Patients that are really wanting to go home or motivated to go home. You can't obviously go home with a blender. So oximizers still definitely have a very relevant place. A lot of the times it really does kind of align with homegoing usage, because you can't take a blender home to use. So trying to find an oximizer that will work for a patient, get them home, and allow them to still be able to function and maintain their saturations is kind of where these come in. Some of the little limitations is you do actually have to kind of exhale through your nose to reset that membrane. I don't know how often people do this perfectly, or if it is as detrimental as what the manufacturing recommends, because I have seen all kind of variability when I've watched people wear these. I do know that if you do get moisture in there, or if you do try to add humidity, it really will stick that membrane, and then you do see the function go down. And then it talks about how it may not be adequate during sleep or exercise. A lot of the times, if someone wears an oximizer during the day, they will sometimes have a secondary device at night, not always. The reason being is if you're passively breathing at night, potentially you might not be able to reset that membrane and keep that reservoir properly functioning. And then with exercise, if you think about really a lot of laborious activity, you're going to be breathing through your mouth and pulling air in through your mouth. So sometimes that can be an issue, but I really don't want you to focus too much on those, because when you think about the typical activity level of somebody with COPD, if they're walking, they're getting very short of breath, and oximizers are standard for people who are going home with oxygen needs that have COPD. So I think it's kind of a weird limitation to have on the manufacturer label, because dyspnea with exertion is pretty common for COPDers, and these reservoir cannulas or oximizers have been successful every time that I shouldn't say every time, but have been successful for a lot of COPD patients. So definitely don't focus too much on those, because I think that although the manufacturer has them as like a liability clause, when you are talking about someone whose lung health has deteriorated to the point where they need a reservoir cannula or oximizer to be able to go home, there's a lot of things that you are just going to kind of accommodate that might not fit perfectly into those boxes. And I just think for exercise, typically speaking, COPDers that are on oximizers have a lot of dyspnea with exertion. So, and they seem to work, if they qualify, work fine. Okay. Stepping out of the low flow nasal cannula, okay, and again, the reservoir oximizer cannula is a low flow nasal cannula, and switching gears into the high flow nasal cannula, which we talked about on the last exam. You guys had it as one of your device interface selections. We talked about that in the high concentration mask. So just focusing on the high flow nasal cannula, you have flows up to 50 liters per minute for adults. On infants, you're typically looking at 1 to 8 liters per minute. There's some variability there depending on size of infant and how big, but that's a pretty good range. You're also looking at larger prongs. When you are on a high flow nasal cannula, it makes sense to have these larger prongs, because the whole goal of this device is to have all of your flow coming from the O2 device itself. You want to be meeting the patient's inspiratory flow needs, so they really want to make sure that they're kind of taking up more real estate in your nostril so that they are able to do that more effectively. It must be heated and humidified. This goes back to, again, that bypassing of the upper airway and why we care about heat and humidity. The other thing that has been kind of a focus of high flow nasal cannulas, particularly with neonates, is that they do provide a small amount of CPAP. That comes in handy, again, particularly with neonates, because sometimes we'll put them on high flow nasal cannula on 21% just strictly to help them with work of breathing. So 2 or 3 liters on a small little premature baby with those nasal cannulas filling their nares and kind of, I don't want to say occluding because that's not the right word, it doesn't occlude, but creating that back pressure, it can help to assuage some of that work of breathing, and then you don't actually even have to provide any oxygen with it. So we use those commonly just to provide a little bit of CPAP for those young ones. You can technically do it in adults. They aren't able to really measure it, but you will see sometimes when you put on a high flow nasal cannula on an adult that it can help their work of breathing just by providing a little bit of that CPAP. You would use this with a blender for precise FiO2 if you're meeting the patient's inspiratory flow needs. This is just a quick little article where they were comparing patients wearing a high flow nasal cannula to patients who are wearing a high flow concentration mask. The patients, and this is more like the subjective data, the patients reported less dyspnea and mouth dryness with the nasal cannula, and the nasal cannula in general, which is not shocking, was more comfortable and better tolerated. Objective data, however, was that the people who were wearing the high flow nasal cannula actually had better oxygenation and a lower respiratory rate. So that's kind of where they started realizing that this could give a small amount of CPAP and help to overcome some of those other works of breathing issues that are commonly associated with people that are needing a higher FiO2. Don't ever think that this is a substitute for BiPAP. It's also really not one that we use as a substitute for CPAP in a lot of situations where work of breathing is pretty high or fluid overload is a consideration. I just want you to realize that this is an added benefit to the high flow nasal cannula. It's definitely not like the main usage of a high flow nasal cannula, and you would never, ever, ever use it to treat an irregular CO2 or a high CO2. These are just some of the examples of high flow nasal cannulas that are out there. This is one that you guys are going to see at Mayo. This is one that you guys are going to see at Gunderson. This is what the Mayo heater looks like. This is the simple reservoir. And then this is what the Gunderson heater looks like. And this is considered more of a wick. And we will look at these in lab so you guys don't have to worry too much about the slide. Again, this is the Gunderson setup. This is the Mayo setup, and we will have plenty of time for hands-on for those when you guys get into lab. High flow nasal cannula wrap-up, basically. It can be used to treat hypoxemic respiratory failure in adults. You can adjust both your FiO2 and flow separately. Acutely ill patients may still entrain room air. What it's saying there is because, and we drew attention to this in the first module, because the high flow nasal cannula can only go up to 50 liters, that's its max, that's not always going to be enough for it to still be a high flow device, because we know that you are looking more at that 60 liters per minute as your top end. Just being aware that if you have a very critically ill patient, a high flow nasal cannula might not actually be delivering a precise FiO2. It might not actually be meeting their inspiratory flow needs. So always be assessing if the high flow nasal cannula is still appropriate for your patient. Yes, they're more comfortable. Yes, patients like them better. That does not mean that they're always going to be an acceptable substitute to the high flow concentration mask. Offers advantages over low flow nasal cannula. So obviously it's comfortable. You get a precise FiO2 for eating, talking, if you have secretions. All of these are advantages. And then again, if you're wearing a mask, you can't do those things. So that's why we like that high flow nasal cannula. It adds molecular water to the airway, so it's safer than an aerosol. So the aerosol that we're talking about here specifically is the large volume jet neb. And the reason that we have to always make that differentiation is when you're talking about the heated humidity that's offered by the Passover heaters, that's molecular water. It does not have the same infection risk as the large volume jet neb, which delivers an aerosol or particulate water. And then another benefit is the may add CPAP, although it can't be measured. And then what this was supposed to be, and I'm not sure why this got in here, because I'm realizing this during our recording, which is always my favorite time to realize that I have a typo. It's just Awesome. This is supposed to be offers the advantages of a low flow nasal cannula, not comparing it to a low flow nasal cannula. So I'm just trying to draw a comparison that it's very similar to if you were looking at a low flow nasal cannula versus like a simple oxygen mask. If you're looking at a high flow nasal cannula versus a high concentration mask, the reason that patients like it is because it's comfortable. You still get your stable FiO2. They can eat, they can talk, they can spit up their secretions without having to constantly be taking a mask on and off. I swear I know my own PowerPoints. I just sometimes lose it in the moment. So that is all I was trying to say there. I'm sure that's as clear as can be. That was the connection that I was making there. Some cautions. So this is something I feel like I notice a lot in clinical setting in the hospital when patients are on high flow nasal cannulas because they're on a nasal cannula. Sometimes the perception is that the patient is not really that ill, or that they are not really in as much trouble as they are from a respiratory standpoint. So again, oxygen does not cure anything. So whenever you have patients that are needing high flow blender devices, you always want to be doing some sort of supplementary treatment, hyperinflation, mucus clearance, whatever the case may be. This is not going to cure your patient. This is just going to help them maintain their oxygenation while you figure out what is going on. So just know that because it's a nasal cannula, sometimes the perception is that they're not really that sick, but these are high flow nasal cannulas. These patients are on usually high percentages of oxygen, high flow. They need other therapies to coincide with that. The flows are not as high as other flow generators, and that just goes back to that 50 liter per minute limit. Some of the things that are obviously higher are going to be your CPAP and BiPAP, which you guys are going to learn more about later, and then just blenders via mask, which are the high flow concentration mask. So big takeaway is a high flow nasal cannula could become a low flow device if it stopped meeting patients' inspiratory flow needs. Again, it's got that limit of 50 liters per minute. Excessive flows in patients with airway obstruction may result in lung injury. So this is something with the immeasurable amount of CPAP that high flow nasal cannulas can give. I'm going to say that although this is a manufacturer risk, what it's talking about is people who have air trapping, people who have very emphysema, I can't say the word, end stage emphysema, we're just going to go that route, where they have blebs and their lungs are kind of deteriorated, where there's more air trapping and the alveolar sacs have been damaged and they're starting to merge together. If you put them on high flow nasal cannula, those high flows could create more blebs, is what it's saying. I've never seen this be a limit to anybody wearing one. So although it's on the manufacturer warning or contraindications, just know that this is not really something we take into consideration at all, either in a clinical setting or on the boards. Now, when you're getting to your little peanuts, like your premature babies, we do take that into consideration. We think about flows, we think about the creation of CPAP because they are so tiny that we are very careful about where we want flows to be, and we always are very conservative with those babies because they're so very small that it does not take much for pressure to create a pneumo or create lung injury. For adults, that's not really a consideration that we take. Not appropriate for a hypercapnic respiratory failure. That just, again, goes back to you would never ever use this as a way to treat somebody with a high CO2. The prongs are larger, so you do have to be aware of skin breakdown. This is from babies all the way through adults. If they're wearing a device for multiple days, you want to be putting in protective barriers. So skin protection such as like Tegaderm or Mepilex, which you guys will see in the clinical setting. Trying to change between a mask and a high flow nasal cannula if you can, to alleviate that pressure. With the little babies, they have a lot of breakdown because usually these are devices that they wear for quite a while and their skin is just very fragile to begin with. And then another thing that can happen is gastric distension. Anytime you have high flows that are going into your nose and mouth, period, some of that gets down into your esophagus because when you think about your trachea and your esophagus and where they're positioned, or a patient eating with high flow on or talking with high flow on, some of that air is going to get into their belly. And so it can create some discomfort there. And again, going back to your neonatal population, they can get a lot of air in their bellies. They actually usually have kind of scheduled times that they make sure to pull that air back off their belly because it will build up so much it can cause problems. One other thing that we're going to talk about that is very low use. I think I've seen it just one time in 11 years. There's not a lot of questions about it, so we are going to whip through this pretty fast. But I just want to make mention, because it is still out there, is there is this thing called a transtracheal oxygen catheter. It is a soft catheter, very similar to a suction catheter, and it's placed in between your second and third tracheal ring, about 2 to 4 centimeters above your carina, and it feeds down into your trachea and delivers your oxygen that way. And this is something that people can use for home oxygen. Flow rates are around 1/4 liter to 4 liters typically. Why would anybody pick this? So where this became, I don't want to say popular, or the people that pick this are that they don't like things on their face. They don't want to worry about having to wear a nasal cannula. This is, in their opinion, more discreet, easier with mobility. For cosmetic reasons, they might want this. Like I said, I've seen it one time, but it's nice to know that it's out there. So how it kind of works is, if they are home and they are by themselves, you would want to hook this up to a bubbler so they can get humidity. They are definitely bypassing their upper airway. Because if they're mobile, there's no way to get humidity with that. They have to be really careful about their fluid intake because they are basically pushing dry medical gas directly into their lungs. So that's something that they have to try to compensate for. It requires daily cleaning. They can flush it with normal saline to make sure that there's no gunk building up in that catheter, because again, it's down in their trachea, and if anything gets in it, it's going to obstruct the flow of oxygen. There's like a cleaning rod that they can use. If they are going to take the catheter out to clean it, a lot of times they'll put in some nasal prongs because then they can still get oxygen while they're cleaning their catheter, and then they can replace it and hook it back up to oxygen. That is all you need to know about the transtracheal oxygen catheter. The other thing that we're going to talk about are called pulse dose O2 conserving devices, PDOC. Basically, these were developed to avoid wasting oxygen tanks. So when you think about an oxygen tank, we've had some hands-on with those in lab. You turn the board on gauge to 2 liters. The oxygen is flowing, right? It doesn't ever stop flowing. What makes this adapter different is this hooks up to the oxygen tank very similar to the board on gauge, but it only creates flow when a patient inhales. So it's considered pneumatically triggered. So your patient starts to breathe in, that creates a negative pressure that makes the pressure regulator essentially kick on. The tank will deliver oxygen to the patient, and then when the patient starts to exhale, it shuts off. So if you're only getting oxygen delivery on inhalation, you are conserving your tank duration. So this is why this became kind of a popular regulator for patients with home oxygen. Anytime you can kind of conserve your tank duration, that's a good thing, especially if you're somebody that likes to be out and about. So some of the cautions with that is it is trigger sensitive, so you can have malfunction there where it stops triggering appropriately on inhalation. The flow rate and bolus size and all these different things can vary from vendor to vendor. So the way that we kind of circumvent that is, if somebody is interested in a pulse dose conserving device, we make them do a 6-minute walking saturation study. So we put one of these on their tank, we put them on what they're supposed to be on, and they do a 6-minute walk. If they don't desaturate in that 6 minute, we consider that that is working well for them. And then they can qualify to get one of these special regulators, and that just is a way for them to conserve their tank more. This is just a summary sheet. You guys can read it just as easily as I can read it, so I'll kind of just let that one go. A lot of this, I think, when you guys get a chance to start seeing it and having hands-on in lab is really going to come together. But just kind of knowing these parameters and understanding them is a good foundation before you come into class next week.